Hi, everybody. Thank you for taking the time to sign on. And tonight, kind of the goals, I will go through kind of what shoulder arthritis is, kind of how we treat it, how we look at it, how I personally kind of my workup and evaluation is, and kind of what to expect if you're dealing with shoulder arthritis or if you're kind of thinking that's what's going on with your shoulder or you just don't know. Ideally, this gives you a little bit of kind of background information. Um, Firstly, that's me. It's my wife and friends and kids, and I do all the kind of same stuff that most of the people who live here do. I like to be outside, and I like to enjoy Central Oregon and everything it has to offer. And I know a lot of our patients feel the same way, and so that's kind of the goal. Um, just a brief kind of academic history for me. I kind of did the march out east, and then I turned around and came right back. I'm originally from out near South Lake Tahoe in Northern California. I went to UC Davis, and then I eventually went to University of Colorado. I did my medical school in Philadelphia at Drexel, which is a bit of a culture shock, but still a great time. And then I came back and did my residency at the University of Southern California in Los Angeles. And then finally went back to the University of Colorado for my sports medicine fellowship. My sports medicine fellowship was very heavy in shoulder arthroplasty and shoulder complex shoulder surgery, which is something that I have a particular interest in, and is something that I'm consistently kind of doing research with, and is a heavy part of my practice. So it's something I like a lot and that I really feel pretty strongly about. What are the things that I do? So I do shoulder surgery, I guess, obviously. So that includes instabilities and fractures and arthroplasty, which are replacements, fracture management. I also do a lot of trauma surgery. So both non-operative and operative management. I do a lot of sports medicine, which is arthroscopic surgery predominantly, but also repairing ligaments, tendons, a lot of cartilage restoration procedures and preservation procedures. Those really focus a little bit more around the knee, but they do have a role in shoulder surgery. We will talk a little bit about those, but predominantly we've learned that large open cartilage restoration procedures in the shoulder is not as beneficial simply because the arthroplasties are just so dang good. We talk a little bit about orthobiologics and kind of what the role they have in shoulder surgery in general. So kind of a brief outline. What is shoulder arthritis and what does that mean? The shoulder is a very complex joint, and we'll talk kind of a lot about it and what we're talking about with arthritis. We'll talk about some of the treatment operative, both non-operative and operative managements. What can you kind of expect from a post-operative care standpoint? And then we'll leave some time at the end for questions. So I think the most important thing about the shoulder that makes it complex is that everybody who has a shoulder or two is a different person, right? So I kind of tell people that my job is to treat a person, not to treat your X-ray or MRI. A lot of how we treat your shoulder, a lot of what we do, how we do it, when we do it is really dependent on activity level, healing potential. You have other medical issues. Not everyone who's 65 acts like they're 65, right? And so I think that age is kind of a number, and it really comes down to what are you trying to do and what are your goals. And I think those are the main things that I like to focus on, particularly when I'm talking to people about shoulder surgery. So what exactly is like shoulder arthritis, right? And there's kind of a few joints in and around the shoulder. The big ones are the glenohumeral joint and the acromioclavicular joint. And the glenohumeral joint is what we're talking about. So that's, if you want to think about it, it's like a golf ball sitting on a golf tee. It's the top part of the humerus bone, the arm bone, and that articulates or produces, it has this joint with the T or the shoulder blade, right? And when we're talking about arthritis in that joint, and we're talking about replacements, this is the joint that we're talking about. It's a complex joint. It's shoulder arthritis in and of itself is wear and tear. Basically what it is if you look at a chicken bone, on the end of the chicken bone, you got smooth stuff, and that smooth stuff's called cartilage. And the cartilage realistically can wear down for any variety of reasons. But in the shoulder in particular, when we start talking about that, it gets very characteristic or common patterns of wear. And that's what we're going to talk about, is kind of the wearing of the ball and the T joint. There are lots of things that cause shoulder pain, and this is but one of them. We're going to kind of focus on that tonight, but understand that there's lots of other things that can cause shoulder pain. But there's a lot of things that we kind of focus on in terms of when we're talking about arthritis in the shoulder, and this is kind of just one of those aspects. So we kind of break down arthritis or osteoarthritis, which is wearing of the cartilage by definition. We break it down into kind of two main categories. We have primary and secondary. So primary osteoarthritis means the shoulder is otherwise pretty normal. What we see is wearing of the cartilage on the bone at the end of the bone. So what does that look like? Well, it's progressive stiffness, pain, loss of function. Osteophytes or bone spurs. It's a bit of a misnomer. Bone spurs, when we think of spurs, we think of sharp things. Bone spurs are actually pretty smooth. When you look at them directly, they're rounded and smooth. And basically what it is it's your body's response to development of loss of cartilage. The body doesn't have any way of making new cartilage. So what it does is it adds bone. And that's what we see. And you can see in those pictures, you can see the kind of looks like a little goat's beard on the bottom there. And that's what that is. That's a little bone spur. But you can see it's not particularly sharp. And that's not what causes pain. What ends up causing pain is the loss of cartilage. Posterior subluxation and glenoid bone loss. What that means is that when the shoulder wears, is the shoulder doesn't wear evenly. The shoulder typically, if it's wearing at the T side, it'll kind of wear the back of the T before it'll wear the front of the T. And sometimes it just wears centrally. And that has a lot to do with kind of the position of the shoulder and the way the shoulder goes on to wear. And just understand that arthritis doesn't wear as an even pattern. And all of these are things that we take into account when we're talking about arthritis of the shoulder. Important to understand that full thickness rotator cuff tears in primary osteoarthritis, like you see in these pictures, actually only occur about 5 to 10% of the time. They really are fairly uncommon. And that's when we say, like, look, the problem here is that your cartilage is worn away. The rest of the shoulder is pretty normal. That's in direct contrast to something like secondary osteoarthritis. And so here we still have wearing and tearing of the cartilage, but it happened for a different reason. And this is what makes the shoulder a little bit more finicky than, let's say, the knee or the hip, is that a lot of times, if you, for example, do have a rotator cuff tear that's been full thickness and has been ongoing for a long time, that can lead to arthritis. And it leads to a very classic presentation of arthritis. And that looks a little bit different than primary osteoarthritis. And it looks different on your x-rays and on your MRI. And basically, if you think of it, the rotator cuff tendons are designed to keep the ball centered on the T. Yeah, they provide some motion, but their real goal is to keep the ball centered on the T. If you lose a couple of them, then what happens is the ball is no longer centered on the T. That causes increased contact pressures, and then what that leads to kind of arthritis. We see arthritis that develops as a result of instability. Instability is when the ball won't stay on the T. So the long and the short of that is the more dislocations you have, the worse it is. There were many procedures that we performed in the early 90s and late 80s and even into the 2000s that we thought, hey, these are really great for keeping the shoulder in place. But it turns out they didn't do so well, and people developed arthritis. There were a lot of things that we've learned about the shoulder and how we treat instability over the years that ideally we can prevent development of arthritis, but we see a lot of that too. Another really common thing that I see is post-traumatic arthritis. So folks who have a break of the ball, like you see in that bottom picture there, where it goes on to heal, but it's not, the way the good Lord put it there in the first place, right? So what you see is that it's healed, it's functional, but then it goes on to develop arthritis. And then lastly, there's stuff like septic arthritis, which is an infection in the shoulder And while your body's really good at fighting off infection, having an infection inside the ball and socket joint is a bad thing, and it tends to destroy the cartilage pretty quickly. That's actually fairly rare. So what are some of the symptoms of shoulder arthritis? And again, this is kind of a very generalized presentation of what folks look like when they come in, but these are some of the things that we see very commonly. So pain, how long is the pain going on, right? Some people will have pain for years and years and years, and it just progressively gets worse. Some people have, a lot of people will develop night pain or difficulties with sleeping. Those are also very common presentations of osteoarthritis. Weakness typically depends, that usually comes in primary osteoarthritis. That's because they've lost their range of motion, or folks have lost their range of motion, which is really the big thing that we see. Weakness can also be loss of rotator cuff or deconditioning because you can't move your shoulder as well. I think it's always really important. I always ask people kind of if they've had surgery, if they've ever had injections, if they've ever been treated for stuff, because that can really change how we approach things with regards to treating your osteoarthritis in your shoulder. Excuse me. Smoking is a big one. We know that smoking can negatively affect healing. So if you've had prior treatment for the shoulder, smoking can be something that can directly influence negatively how you're healing and how you go on to heal from future procedures. And then I think this is a really important question that I ask everybody, is that out of 100%, if 100% is a normal shoulder, right, and 0% is I can't use it at all, it is completely unusable, you might as well cut it off. That's it's a helpful barometer for how your shoulder is, because again, for a patient, you live with this shoulder. I don't live with it. I can fix it, but at the end of the day, you live with it. And so it gives us a good idea of, okay, where are you in terms of how this affects your life? I kind of describe everybody's shoulder as a snowflake, right? So everybody's shoulder affects them a little bit differently, whether it's their dominant or their non-dominant arm, whether they are, how debilitated they are, right? Some people, they have the same exact x-ray. Some people say, yeah, this is like a 10% shoulder. And some people say, hey, this is a 90% shoulder. It just bugs me every now and again. So that's where I think it's really important to kind of drill down on what are the things that are bothering you and how is this affecting you. So if you come in for a shoulder examination and kind of evaluation, there's a lot of things that we take into account. Keep in mind that my goal as a surgeon in the office is really not to sell you on anything. That's not my goal. My goal is to talk to you about your shoulder, to help you understand what's going on with your shoulder, and to provide you the list of options that we have. In that, right, it's going to take a little bit of time. My goal is not to rush you through things and to help you figure out, okay, what are the things I can do for this pain that's it's been ongoing. And I think arthritis is really more of a discussion. There really is a lot of back and forth and understanding, okay, how does this affect you, and how does this, what can I do for the things that are affecting you? We usually give you intake forms. Those are actually really helpful for us. I read every one of them. I go through them and I make sure that, okay, these are the things that are going on, and we kind of try and touch on those as much as I can. You'll usually get x-rays. I hear a lot of patients, well, I already have an MRI. I don't really need x-rays. Keep in mind that in order for me to make a lot of the diagnostic decisions that I'm going to make, an x-ray is exceptionally helpful. Also, when I'm comparing post-operatively, I don't get post-operative MRIs on everybody, and usually I get them very rarely after shoulder replacement, but I do get x-rays very often. I look at a lot of x-rays during the day, so that's something that I'm constantly comparing to. And a lot of the kind of management that we'll make, we actually don't, when we're talking about shoulder arthritis, we actually don't need an MRI. And that's, again, some of that stuff is really helpful for us, and just understanding that, yeah, and x-rays are an important part of coming to see an orthopedist, especially someone in the shoulder kind of sphere. Obviously, a history and physical exam. I try and apologize to people, especially if you have ongoing shoulder arthritis. I'm going to make your shoulder mad. I'm sorry. I don't do it on purpose, but I'm trying to figure out, okay, what are some of the physical exam signs that are going to help us lead to what's going on with your shoulder, number one, and number two, what are the things we can fix? And then I really try and take the time to explain not only the operative management, but the non-operative management. This is, again, it's a discussion. The goal here is not for me to just have you walk in and say, hi, you need a shoulder replacement. I actually don't like doing that. I think it's more important that you understand that what's going on, and then how we go from there. So let's talk about a little bit about kind of our non-operative options. I think so. These are things that I talk a lot about day in and day out. This is the cornerstone of how we treat stuff, right? As a surgeon, sometimes when you're the hammer, everything looks like a nail. But you also have to understand that sometimes the best surgery you do is the surgery you don't do. And so understanding that the shoulder is a complex joint and requires a lot of different approaches. And so to me, non-operative options are equally as important and have an equal role as operative options. One is activity modification. People hate hearing this, right? This is, if it hurts, don't do it. But that being said, sometimes there are certain activities that you do that particularly are bothersome to your shoulder. And if you have ongoing arthritis, those may not be the best options for you. And you may have to come up with strategies to help you modify those activities so you can still do the things you enjoy, but help ideally avoid surgery if that's kind of what our goal is. NSAIDs, which are non-steroidal anti-inflammatory drugs, are really helpful. So there's excellent evidence to suggest that Tylenol is actually one of the best arthritic or medications for arthritis in both the knee and the hip. The shoulder follows that well. NSAIDs, things like ibuprofen or Tylenol, or sometimes prescription anti-inflammatories, are indicated and can be very helpful. I think there are topical NSAIDs, there are topical creams, salves, lotions, those kinds of things. And the way I look at it is, if it helps you, great. Those are awesome medications. They have a role. They're things we like to try. Again, if we can avoid surgery, then that's what we want to do. For osteoarthritis, we talk a lot about injections. So injections come up for all sorts of things in the shoulder. When we're talking about the ball and socket joint, this is what's called an intra-articular steroid injection. And this has a large role in my practice because I think it provides two things. Number one, it provides relief. So a lot of people who have bad arthritis in their shoulder, this is going to give you some relief. How long is it going to last? Well, that's going to depend on kind of a lot of different factors. But it also is diagnostic. It really tells us, hey, how much relief are you going to get from something like a shoulder replacement if we're discussing arthritis, and what can you kind of expect from that? We can do these either with an X-ray or an ultrasound. I have great partners who are real slick with the ultrasound and with X-ray to get that in exactly the correct spot while we do a steroid injection. There's pretty good evidence to say that unguided injections can be nearly as accurate as a guided injection. And so what I will often tell people is, I can tell you I'm about 95% accurate. If you want 100% accuracy, we typically go with a guided injection. PT, I always put a question mark around this when I'm talking about shoulder arthritis in general. Is when you have bad arthritis, the cornerstone of PT is motion in the shoulder, right? So there's strengthening, there's mobility, but really motion is the big thing. The problem with shoulder arthritis is that it's a disorder of motion, right? You're losing the ability to move the shoulder because the cartilage is worn, and therein lies kind of this juxtaposition where the problem is you want to move your shoulder to get better with PT, but it hurts to move your shoulder. So I think PT has a role in a lot of things around the shoulder. Sometimes arthritis will say, hey, this may not be the best modality for you. So let's talk a little bit about what are replacements. So these are kind of the two general types of replacements that we talk about. There are some others, but those are a little bit out of the scope, and they're a little more selective cases. These are the two that I do predominantly in my practice. And these are generalized examples of implants. They're always the implants we use, but on the left, you see what's called an anatomic total shoulder replacement. And again, that's for primary glenohumeral osteoarthritis. And that means arthritis where the rotator cuff is totally intact. So when we think of a anatomic shoulder replacement, We think of it as basically a normal shoulder. All we're doing is resurfacing it. It's a little more invasive than that, but generally you can think of that. Alternatively, if you have arthritis that you've developed because of additional reasons or secondary reasons, well, it's pretty common that we'll use a reverse shoulder replacement. They're both total shoulder replacements, meaning that we replace both the ball and the T side, and we have various reasons for using those. The majority of the time, when we're talking about a replacement, a lot of people over the past 10 to 15 years have really shifted to using the reverse total shoulder replacement because as a procedure that was basically a salvage procedure in the early 2000s has really come into popularity because the implants have gotten so much better and people do really, really well. That being said, an anatomic shoulder replacement really has a great role in shoulder replacement surgery as well. Ultimately, when do we decide that it's time for shoulder surgery? That's not for me to decide. That's for you to decide. And so that, I think, is kind of the most important thing about any evaluation. And when we're talking about a shoulder replacement, and why I don't like, hi, you have arthritis, you need shoulder replacement as a beginning to a discussion with a patient, is it's not up to me. I don't live with this shoulder. You do. There are lots of options that we can go. And ultimately when we decide, that's the patient's decision. And I'm here to help with that. So kind of taking a step backwards, what kind of replacement am I a candidate for? Really, the first question we ask is, how's your rotator cuff, right? If it looks okay, right? Like we said that majority of the time it does in primary osteoarthritis, that may be something where we consider an anatomic total shoulder replacement. If it's not, right, or it's been torn or it's been compromised by prior repairs or prior tears, or if the deformity on one side or the other is too complex that an anatomic won't work particularly well or won't give you the best outcome, a lot of times we may suggest a reverse as our first option. This is why it's a complex discussion. We're constantly kind of going back and forth, and a lot of times it's confusing, but the basics of it are if your rotator cuff is otherwise healthy, an anatomic may be the best option. If it's not, the best option may be a reverse. And we kind of go through both of those, and I'll explain a little bit what the nuances of those two are. So who gets an anatomic? This is someone who has primary glenohumeral osteoarthritis. They have a small or functional rotator cuff. They have good bone stock and version. What that means is that the position of the T and the position of the ball are appropriate, that they will basically have a normal shoulder once we kind of replace the arthritic portion. This is a big one, compliant and able to rehab. So because an anatomic is so important that the rotator cuff tendons are perfect, essentially, compliance for rehab is really important because you got to get it to heal. If it doesn't heal, the anatomic fails, and then you go on to need and repeat surgery, and that's not fun for anybody. But this is a very successful procedure, and folks do really well. I think it's important to point out that says failed conservative management, right? So you've tried all the things. If you try all the things and you go, hey, this is just not getting better and I am not going to live my life like this, then we may be considering, shoulder arthroplasty, and a primary or an anatomic shoulder replacement is a great operation. It's a very reliable operation. I tell people that if you are indicated for this, and it goes well, it's kind of like hitting a home run. Everybody's happy. It does really well, and it's basically a normal shoulder, which is really nice. Contraindications, so reason we can't do surgery, right? So if you have an active infection, obviously, excessive bone deformity or subluxation, that means if the T is so deformed or is worn in such a way that it won't hold the plastic portion of the shoulder replacement, that's not a good person for an anatomic. But the good news is that you have other options, and we'll talk about those in a second. Rotator cuff tears that you cannot repair. Those are oftentimes reasons that we won't suggest an anatomic shoulder replacement, or deltoid dysfunction, which is another really important portion of how your shoulder works in terms of motion. So who gets a reverse total shoulder replacement? You can see there that the reverse looks drastically different from one side to the next. So sometimes we see folks who have arthritis that have developed this irreparable or have a large rotator cuff tear that's been ongoing. That's a person who's going to do really well with a reverse. If you have a severe glenoid or the T side is very worn, that's a person who does really well with a reverse as well. In those two settings, I will say that we do know with the modern reverse and with modern prostheses is that we used to say an anatomic, man, you get such better range of motion with an anatomic versus a reverse. And it turns out that gap is really closing. And there's some really nice literature that's come out recently that says, hey, the reverses as a primary operation do really well, and we're starting to get much closer in terms of our functional range of motion that we can achieve with a reverse total shoulder replacement that's put in well for the right indications. And I think so just because you have to have a reverse no longer means that you know you're going to have severe loss of range of motion. The other things that we tend to use a reverse for is large fractures or fracture dislocations. Sometimes those are candidates for plates and screws. Sometimes a reverse total shoulder replacement is the best way to go, and you get the earliest and quickest range of motion, and we know you'll get the best functional outcome. I do a lot of those. I think that people do pretty well with them. There's a good body of evidence saying that people do pretty well from those. Proximal humeral bone loss, which can be as a result of prior surgeries or sometimes tumors, revisions of a total shoulder replacement. So it's very, very common that if we need to redo or if you have a failed anatomic shoulder replacement, lots of people had anatomic shoulder replacements put in 20 plus years ago. Those people do really well if you go on to revise them and turn them into a total reverse total shoulder replacement. And again, it's coming down to, do you have basically a normal shoulder or an abnormal shoulder? The contraindications are pretty similar, right? Active infection, metastatic disease. This one's really important though, because you change the biomechanics of the shoulder. You can't have deltoid dysfunction or axillary nerve palsies, which are that's the nerve that controls the deltoid, because that's basically how you gain the motion in your shoulder, because you change the mechanics of the shoulder. You no longer need the rotator cuff tendons, but you do need the deltoid. So I think this is a really important thing that I talk to a lot of my patients about. The thing that has changed shoulder arthroplasty probably most in the past 5 years is the use of advanced imaging to help us plan placement of the implants. This is one of a couple different proprietary programs, but basically what we'll do is for all of my patients that get shoulder replacements, I will get a CT scan, and the CT scan, really what it does is it allows me to build exactly what you see in front of us. This is just a screenshot, but what you see is this is a 3D model of your shoulder, and we build the 3D model of your shoulder. And then what I do while you're at home, presumably having coffee, will put all the different sizes of implants. I'll put the position of implants. This has, essentially we'll run it through a motion analysis to see where the implant's going to run into each other. How can I get you the best shoulder that I can with the implants I have available? And so on the day of the operation, when I come in, I already have the plan. I know which implants are going to fit best, and I know ideally where I can put them. And we can generate specific guides to put them exactly where we need to in complex surgeries. And we go on and all we have to do is execute the plan. And so we've gone from, potentially needing 6 different sizes and going through and trialing each one of them to using 1 or 2 and realizing, hey, this is probably the best, what's going to give you the best outcome. I think it's also important to state that there are lots of companies, just like if you're having a deck built or you're having something remodeled on your house, right? You don't go in and tell the carpenter, listen, you have to use a Nikita, you have to use the DeWalt, or you have to use a Craftsman, right? You don't care, right? The goal is that let them use what they're going to use and what they're most comfortable with. Are there nuances between different implant companies? Yeah, sure there are. But at the end of the day, you want your surgeon to put in what your surgeon's comfortable with. And all of the implants make great products. It really comes down to how you do the surgery and kind of what your training was. And that changes from time to time, right? As new companies come out with newer products, sometimes we change what we use and how we use them. These are kind of some of the anatomic variations that we see. We see there's ones with small stems. Those are probably like, 2 to 3 inch long stems. You can see the plastic there. These are kind of the plastic pieces that you see that get impacted or cemented into the T side. We also have what we call stemless varieties, which these look like these little cones that you kind of impact in there. A lot of that depends on bone quality, what we're trying to achieve, and ultimately how a shoulder replacement we think will get you the best result with the most stable result. What about a reverse, right? So again, you can see the stems actually over time, we've learned that the stems work pretty darn well in a reverse, and they look very similar to what an anatomic looks like. Just the very top portion is flipped around. There's been a big push over the past 10 years to make things convertible, right? So we don't have to take the stem out to put a new reverse in. That's been a very big push for a lot of companies, because taking the old stem out is hard, quite frankly. Sometimes it comes out easily. Sometimes it comes out with a pretty big fight. What you see here are kind of just a different variety of stems. This comes back same principle, right? What goes in is what your surgeon's comfortable with and what they think is going to give you the best result. And so it kind of just give you various examples here. So let's talk a little bit about the kind of what to expect the day of surgery. So, if we've gone on and we've decided, all right, we're going to proceed with surgery, I think it's this is where we go, okay, what can you expect from this? First off, when you come in, a lot of people are going to ask you which side we're operating on. That's normal. We're supposed to do that. We're going to do that. I ask everybody to mark the side that we're working on. I'll mark the side that we're working on. We never, ever want to have that be a concern for us in the operating room as to which side we're operating on. There's a lot of things going on. People are nervous. There's a lot of questions they're asking, but this is one that, yeah, you're going to get asked a lot of times. That's a normal thing. Many people, you'll talk to your anesthesiologist. You still get general anesthesia for these. You go all the way to sleep. I tell people that while it would be wonderful for you to be awake, neither of us want you to be awake while you're having a shoulder replacement. Nerve block is some people elect to have it. Some people elect not to. The nerve block is essentially putting numbing medicine up in and around the neck that numbs the whole arm. It puts the whole arm to sleep. It lasts usually, depending on the nerve block, it'll usually last a day or so, but it's really helpful for that first 24 to 48 hours where surgery can be pretty painful after this. Most patients will go home the same day. At the beginning of 2024, we had the ability to start doing shoulder arthroplasty or shoulder replacements in the surgery center. So a non-hospital setting. That was a big thing for us as surgeons, because now we can treat people and they can go home the same day. And we know that you'll do very well at home. But that being said, I always discuss this with my patients beforehand. There's no reason for me to tell you have to go home if you're not comfortable going home. I don't care if you stay in the hospital. It doesn't make any difference to me, right? I want you to be comfortable and I want you to have a safe and good outcome. And that's what I tell patients. And I think that that's ultimately what we want. If you're comfortable going home, great. You're probably going to sleep better. But, I think it's an important discussion to have with your surgeon beforehand. A lot of people ask, how long does it take? Look, it takes as long as it takes, and I don't leave until I'm happy with it. All right. And personally, if it's me or if it's my family member on the table, that's how I like to treat my patients. And that what I want is I'm going to take as long as I can until I get it perfect. That being said, usually by the time you go back, get set up, have surgery, come back out, 2 to 3 hours. That's about how long it takes. There's pluses and minuses depending on how we do it, how long it takes, what we need to do, whether we're revising or changing something. But ultimately, that's kind of the long and the short of that. So what do the first kind of weeks look like post-operatively? The first thing is, the first weeks, really, you're in a sling. How long you're in a sling, the protocol you're on really depends on whether you're doing an anatomic versus a reverse. Reverses, again, you don't really need the rotator cuff to heal. You try and get as many of you get as much of the rotator cuff tendons to heal as you can if you do repair them, which you usually only repair the subscapularis, which is the rotator cuff tendon in the front. So in a reverse, while that's really helpful and can provide a lot of benefits post-operatively, it's not necessary. So we tend to, with a reverse, be a little bit more liberal in terms of letting you move and be out of the sling earlier. In an anatomic, we have to have everything heal, so we tend to kind of keep you in a sling for a little bit longer. I put on there a picture of the cold therapy unit. I think these things are great. They're worth their weight in gold. They don't pay me to say that. I think they're just a really good invention, and they work really well. Sometimes they're covered by insurance, sometimes not. They generally cost about $150, but if you're having shoulder surgery, this is something that I think you should strongly consider. And basically what it is it's a little igloo cooler that has a motor in it that just pumps ice water in and around your shoulder. And those first couple of weeks, this thing can be a lifesaver, as opposed to running to the freezer and grabbing ice bags and stuff. Physical therapy is a great adjunct. I use physical therapy a lot for my patients. I think that they do well. Not everybody needs physical therapy, and there's actually good literature to say that for some shoulder surgery, you probably don't need physical therapy. But I think that really is, again, individualized, and I tell people that that's not going to hurt you. And I think that having someone to guide you and kind of monitor your progress and go in and have an expert in strength and exercises that can kind of work with your surgeon to get you the best outcome. If that's available, then it's great, and then we should be using it. There's a little icon here for a clock, but that I must have lost somewhere. But I think this is the biggest thing, right? So you'll be on medications for pain, typically medications for blood clot prevention, medications for constipation, and medications for nausea. I tell patients, just set an alarm. Just take it, right? The goal here is that you have your pain well controlled so that you can move your shoulder and you can get up and move around. That's what we want you doing. The more regimented you are with that, the better people tend to do. But those are kind of the medications to expect that you get post-operatively. I typically see patients at 2 weeks, 6 weeks, 3 months, 6 months, a year, 2 years, and 5 years. I tell people that once we put a shoulder replacement in, I'm going to see you on a routine basis until one of us gives up. And the key here is that this is something that is designed to be in you for the rest of your life, presumably, right? The modern shoulder replacement is designed to last approximately 20 years. When we put these in, we have to monitor them. We have to watch them. You don't really, because ultimately it's plastic and metal, and at some point it'll wear out. But ideally, you slow down or wear out before it does. This is just a copy of or a kind of a screenshot of what my protocol looks like. You can see it's kind of got our website. It's got a QR code to go to that protocol. What I tell people is the protocol is really just a set of boundaries and kind of some guidelines for you to work on at home or to work on with the therapist that you see. I think my goal is not, when I send you to physical therapy after a shoulder replacement, my goal is not to tell the therapist exactly what to do. My goal is to say, hey, these are the parameters that I have to set based on what I did. And as long as we can stay in those, they're the experts in therapy, and they're going to get you where they need to go with the exercises they have. Sling is roughly about 6 weeks. Again, depends on reverse versus anatomic. Pain control is a big topic that we tend to talk about after shoulder surgery. We have lots of options. Not all of them involve narcotics. I really try and make individualized post-op plans for folks to try and figure out, okay, which pain medications are going to work, which are not going to work. Most people need pain medication after shoulder replacement surgery. How long you need it? Sometimes a couple weeks, sometimes a couple days. Everybody's a little bit different. The one thing that is not different through pretty much everybody is sleep. So sleep is a big issue after shoulder surgery. That's all shoulder surgery. Shoulder replacement surgery is no different than that. I will tell you that people tend to recover from shoulder surgery, arthroplasty surgery or replacement surgery, typically a bit quicker than they do from arthroscopy, which is, again, kind of counterintuitive. But I have a lot of patients who say, well, listen, I had a rotator cuff repair that was done arthroscopically. And I do lots of arthroscopic shoulder surgery. And I'll tell you, yeah, people, they do not sleep well for a while. And you think, well, there's all these little tiny incisions. Why not use that? That must be the best way to go. And sometimes it is, and sometimes it's not. Sometimes the arthroplasty really you recover from much, much quicker and you get back to sleeping, which is a big issue. This is kind of the only thing I need to say about sleeping after shoulder surgery. You just get used to the recliner that you're going to sleep in. You don't have to buy a recliner, but really sleeping sitting up is typically much more comfortable than sleeping laying flat. I think one of the best things to kind of anticipate and set yourself up for success is helping get your bedroom or your sleeping situation set up to where you're going to be more upright for the first few weeks, and then you'll gradually work your way back down. In my clinic, I use, this is kind of the last few things we'll talk about in terms of what to expect post-operatively, but a lot of people ask me, like, why do you use all these questionnaires? Why are you filling out all these forms? You can check all these boxes and calculations and such. And our literature in orthopedics is heavily based on how people do, their outcome studies, right? Their validated responses and questions that we look at. And to me, the way I explain it is this is an objective measurement of how much you've improved. I like to get them before and after. I want to know how bad really is your shoulder, because 3 years from now, you may say, you know, I don't remember my shoulder being that bad, right? And you look back and you go, actually, if we look back at these scores, you were not doing so good, and this is where you are now. And I think it's a nice way of objectively looking at exactly how much you've improved. And really, the other thing that helps is we go back and we look at this and we say, hey, this is the technique I'm using. And it turns out my outcomes were a lot better if we kind of pool people together. And this is how surgeons learn and grow and how we develop new techniques in orthopedic surgery. This is what I tell patients, right? My job when you come in for a shoulder evaluation, especially with arthritis, is to give you the menu, right? My job is not to sell you on stuff. I'm not trying to pitch one thing or the other. My job is to give you the menu. Your job is to order. I'm here to tell you what the specials are and exactly how they work. Okay. Lastly, the thing for us, you know, I think one of the things that we kind of value here at the center is outcomes. We want our patients to do the best that they possibly can. We also live in Central Oregon. We love the same things you do as surgeons. We have patients that want to go out. They want to be active. They live here for a reason. Our goal is to get you back to that. We are a large group of fellowship trained experts in almost every subspecialty. And really what we're trying to do is we take evidence-based care and data-driven care to get you back to what you want to do. And that's it. That's what I got. So at this time, kind of what we'll do is we'll start answering questions, and we'll kind of go from there. Hang on, I'm reading through them. So one question that came up is how long till you can kind of return to activity? I think it depends on the activity. A lot of times what I'll tell people is at 2 weeks, you should start getting used to kind of coming out of the sling every day. At generally around 6 weeks, we'll start in on kind of daily activities. So using the shoulder to essentially do activity, you know, eat breakfast, get stuff out of the refrigerator, you know, make your bed, that kind of stuff. Generally by 3 months, you're more looking at normal day-to-day stuff. A lot of patients that go out, and by that point, they're kind of out doing, you know, yard work outside. Some people are back to kind of skiing, Nordic skiing, stuff like that. And then usually by 6 months is kind of when I tell people that I would like you back to doing your normal thing, because we know you'll kind of plateau. Well, you won't plateau, but you'll improve out to about 6 months, and then what happens is that kind of curve kind of slows down. But we know that you'll improve in terms of range of motion out to about 2 years. There's a question: how long have I been at the center? So I started here in January. I originally moved to Central Oregon from Colorado as a group based in Vail, and we moved here with my wife and family. We initially started at Desert Orthopedics, and then through a variety of things, what we ended up doing was merging the two groups together. So now we have one singular group at the center, but I've been here since about January. Second question: how long before you can drive again? Really depends. You can't drive with a sling on. I mean, you can, but you shouldn't. I will tell you that most folks are driving around between 2 and 4 weeks after surgery. Impingement, and then there's a question about, can you speak on impingement syndrome and if that can lead to arthritis or worsen arthritis? So impingement syndrome is an interesting thing. That's a large, broad topic that is filled with bear traps. However, what I will tell you is this: impingement syndrome, and what you're specifically referring to probably is what's called subacromial impingement. And what that is an irritation of the rotator cuff tendons. There is some evidence to suggest that impingement syndrome, or more specifically an acromion or shoulder blade that narrows the space available for your rotator cuff, can lead to increased risk of rotator cuff tear or rotator cuff re-tearing. And that can ultimately go on to develop arthritis or put you at slightly higher risk if you're kind of extrapolating that. Currently, there's no evidence that says that having impingement syndrome by itself can go on to lead to arthritis necessarily. But again, through kind of 3 degrees of separation, you could certainly make that argument. The big thing for impingement syndrome is really understanding that keeping your rotator cuff strong and treating it early is an important way, or usually conservatively, is an important way of keeping your shoulder health. Hang on one second. So someone's kind of given an example of working out using incline bench and using their shoulders, or an incline plane like a reformer, and whether they should go back to using that at about 25% of the weight, or modifying activity. This is exactly what we're talking about when we're talking about modifying your activity. That's a great idea. Ultimately, going back and modifying things like on a reformer, on band exercises, is really that's what the kind of crux of using your shoulder is. How and when you do that really is determined by how well you do. If you have shoulder pain, even though you're modifying your activity, sometimes you need to be considered, okay, do we need to evaluate this further? Do we need to try something else? But yeah, I think that's a great plan, great way of looking at it. Give me one second. So someone's given the example that they kind of took a spill off their bike, and they kind of have, sounds like kind of ongoing shoulder pain and irritation. Here's what I'll tell you: whenever you fall off a bike, no matter, or fall skiing or fall anywhere, right? You always run the risk of injuring something in the shoulder. We know that you don't always have to have a fracture to disrupt something in the shoulder. What I would say is that Many people that I see have gotten to a point where their shoulder bothers them consistently, and usually it's when it starts interrupting their sleep. If that's the case, right, and it's been ongoing, and if it's been going on for a year, 20 months, whatever, right? That's usually, give us a call, right? Like that's something at some point, something's going on. That's usually where an x-ray will give us some valuable information, and sometimes an MRI or really a direct evaluation is kind of the best way to evaluate that. And give you the best kind of answer about what you would do. But that's what I would do. Hang on a second. Yeah, so someone's asking a question about, should you wait until the shoulder is painful to a specific level, or it becomes painful more often and more consistently? I think that really is best answered by how much you feel the shoulder irritation kind of disrupts what you're doing. Here's what I'll tell you. There will come a point in every patient that I see that you will not that your shoulder pain is disrupting what you want to do. And I think whether that's a particular amount of pain or whether it's a specific activity, like in this example, I was talking about splitting wood. If you're going out and you can split wood and you can get a half cord in and then you can't move for 3 days afterwards, well, yeah, that's probably the limit for you. And we should probably be thinking about that. Might be something that we need to evaluate further, particularly if splitting wood is an important thing for you. Other patients may say, hey, you know what, this doesn't bother me. It's not super painful, but it bothers me all the time. And that may be kind of the deciding factor for them. Personally, I think how you treat it and when you treat it ultimately comes down to you and how disruptive the shoulder is to you and your activities, whether it's super painful or whether it's painful all the time after those activities, or limiting those activities is really kind of helps guide you when you come in for evaluation. Someone asked a question about a partial shoulder replacement. So partial shoulder replacements for a long time had an excellent role in shoulder surgery, and we still do them. Partial shoulder replacements have really, over the past probably decade, have really started to be replaced by, no pun intended, replaced by development of better and better total shoulder arthroplasties. That being said, the partial shoulder replacement certainly has a role. It has a role in my practice. I think it's a great option for folks who are really, really young and that this is probably not going to be their last replacement. Again, partial shoulder replacements that need to go on to total shoulder replacements, a lot of times, just speaking very generally, oftentimes will need to be converted to a reverse. Not always, but sometimes. And I would say that's probably the majority of the time. But with that being said, many people have partial shoulder replacements that go on and live totally fine lives and don't bother them at all. If they do bother you, again, this is why we kind of continue to watch and evaluate both anatomic and partial shoulder replacements. Someone asked if I'll do a similar program on hips. I have excellent arthroplasty colleagues that do mostly knee and hip replacements, and that's specifically what they were trained to do. I do hip replacements in the trauma setting predominantly. Elective hip replacements, I certainly do some, but I have arthroplasty colleagues that do quite a bit of them, and I focus kind of more on the shoulders. But yes, we do have programs similarly for our hips and our knees, because a lot of the stuff that we're talking about with the shoulder today is really, really applicable to hips and knees in terms of how we work up and how we do surgery. Recovery is a little bit different. Approach is a little bit different. But yeah, that's what I'll tell you, that yes, we do have those. I think we got a couple minutes left. If anything else comes up, we have Olivia put on our website. You can Google the center organ and look us up to both there on YouTube and on social media to kind of see exactly how you can get in. Please don't hesitate to give us a call. And I'm happy. We're typically do my best to get as many people in as possible, as quickly as possible, to kind of help figure out what we can do and how we can get you feeling better. So there's one last question, I think. That's a very broad question. It says, what is the impact of arthritis? And I think whether that's a philosophical question or in my own practice or to a patient, and I will tell you that in the shoulder, right, it is quite depending on how severe the arthritis is, but profound would be the short answer. So the impact of arthritis on the human body is typically very poorly tolerated. But to that end, right, that's why we've over the past 100 years developed some pretty incredible operations to kind of fix that. I think with that, we'll wrap it up. Thank you guys for attending, and I appreciate it. And hopefully we've answered your questions. Please don't hesitate to reach out and ideally if anything else comes up. Thank you.